In
this chapter, we will be dealing with erosions and abrasions. These are both important topics and gaining in importance in today's times. This mainly concerns erosions and, in some cases, also abrasions and bruxism. One needs to differentiate these cases, although they are sometimes present together. Erosion means that we have a loss of tooth substance. This is usually due to acids, in other words, of a dietary nature. It's therefore appropriate to examine why the patient has erosions. If the reason is dietetic, then the problem is easy to solve. If we are dealing with an underlying disease, anorexia nervosa or bulimia, then further medical intervention is necessary. But it's also known that approximately 20 to 30% of erosions are of an idiopathic nature, meaning we do not know exactly why enamel is being lost. The fact remains the lost enamel or tooth-hard substance need to be replenished. Now, this is relatively simple to do with a satisfying experience for all concerned. For patients as well as dentists, this is a relatively simple procedure. In this case on the left, we can see slight abrasion of the incisal edge and a slight malposition of number 2. Buccally, we can observe a slight loss of enamel and, in part, some exposed dentine areas which can lead to hypersensitivities. In part, they are also discolored as dentine is more inclined to discoloration. In this case, all we need to do is replenish. This is why it's sufficient to only clean and condition the tooth surface. The presence of enamel gives a frosty white appearance. This confirms that etching has been performed. The primer is used for dentine. As no major background corrections are necessary, we can place Componeer directly using the same restoration material from which the shells are made. One can see well how Componeer White Opalescence is placed together with Synergy D6 White Opalescence. White opalescence restores the brilliance of teeth again, and they become somewhat brighter. This can be seen especially well in the slightly darker areas, proximal and cervical. But the translucency of the material allows natural dentine to shine slightly through the material. In this case, we have erosions. We cannot see any abrasions, but one can see 2 old composite structures which I had prepared myself 10 years ago. If one takes a closer look, one can see erosions in the cervical area. One can now see a slight abrasion on the canine. Part of the tip has been lost. One can also observe a slight inclination of the premolars in palatal direction. The dental arch is also somewhat narrower and lyre-shaped. Therefore, I decided that there is no real need for preparation here. I simply ground the surface of the old composite restoration. However, not to the base. One can still see remains of the composite material here. As no secondary caries or anything else was assumed to be in the background, and as the colour match with the remaining hard tooth substance was also acceptable, no further grinding was necessary. Here again you can see the frost-white appearance of the enamel as a result of etching. The exposed dentine areas were, of course, blanked out for etching. The first Componeer was placed in the correct position. It always pays to take sufficient time with the first Componeer, as this serves as marker. Once the first componeer has been placed properly, then the others are easy to place. In the case of erosions in the cervical region, it sometimes happens that the componeer length is not sufficient. As already mentioned, the componeers have ideal proportions in terms of length and width. And in the case of tooth neck defects, these ideal proportions are, of course, too short. There are two options to counteract this. If they are larger or represent real defects, one can first fill the cervical defects. Or they can be covered simultaneously with the componeer if using the same material. In this case, there was no major discoloration in the cervical area and the dentine had virtually the same color of the teeth. If we cover cervically with normal translucent enamel material, we obtain a profile from the brighter surface to the cervical edge at the same time. It is generally recommended to add a profile if the teeth are too bright or become snow white at the cervical margin. Otherwise, componeer would become conspicuous, as the natural teeth are, of course, not that long. This optimizes the tooth length somewhat. The componeers have now all been placed. At the same time, the teeth in the cervical region are extended and covered to give a certain natural appearance. Hence, the proportions are also maintained when smiling. It also positively proved to move slightly outwards to the left and right with the premolars to extend the dental arch. The tooth contours are now completed again and covered. And this results in a resistant and natural tooth surface. And to be precise, these are componeer surfaces. Here we can see a combination of abrasion and erosion. A 44-year-old former bodybuilder. Training to excess was one of life's hazards, and he certainly sunk his teeth into it. On the one hand, we have an abrasion caused by bruxism and a simultaneous erosion of a dietary nature. As we know, sportsmen often consume large volumes of acidic isotonic fluids, and this then damages the enamel regions as a consequence. You can see completely exposed islands. In other words, erosion plus abrasion due to bruxism. The second problem is the combination of natural tooth substance and ceramic crowns, which we will discuss in greater detail in the Chapter 4 on the repair of ceramics. Crowns had been provided at an earlier stage as a result of abrasion due to bruxism and erosion. You can see the lateral incisors and the crowned premolars. Nonetheless, it was possible to optically correct all teeth with componeer or reconstruct the missing sections with componeer. The surfaces of the ceramic sections were prepared somewhat. This reduces the ceramics. It is especially important to remove the glazing of the ceramic to obtain an optimal as possible surface for adhesion after subsequent sandblasting or etching. In such instances, it is important to inform the patient that the bonding power to ceramic is roughly 30% less than to natural tooth substance. This is particularly important in patients with bruxism who have a tendency of grinding their teeth via the incisal edges. The likelihood of chipping or a defect is simply greater than with natural enamel. But as long as we inform the patients, this is not a problem. The crowns were treated with a 4.9% hydrofluoric acid, etched with ceramic etched, silanized and bonded. This allows restoration of the contours and protection of the teeth for a certain period of time. Here we see no erosion but abrasion caused by mild bruxism. This is mild bruxism via the anterior teeth, as demonstrated by the canines. Abrasion of the canines is not particularly pronounced, just slightly on the palatal surfaces. The pointed tips of the canines are still present. In other words, we're dealing with a slight protrusion motion. At the same time, we can see that the teeth are relatively inclined. This means we have a deep bite situation, which causes the patient to grind her anterior teeth. The question now is, should one lengthen and restore the teeth, or look for an alternative solution? In the introductory chapter, when we discussed preparation, I explained that we need to prepare a palatal counterbase. So, if we have a protrusion motion, we need palatal composite to distribute the forces across the tooth. In addition, the present shape of the teeth represents a bad habit. This means patients feel that their teeth fit well and therefore they start playing with their teeth. As soon as the teeth no longer fit well due to protrusion guidance, then this bad habit is usually eliminated. Patients then tend to stop grinding their teeth automatically. Diagnosis was implemented, and it was decided we could move the anterior teeth slightly to the front. As they are already fairly inclined, this gives us the opportunity of building up sufficient material to restore the anterior teeth in a sustainable manner. Actually, there's no need to prepare the teeth, as we have palatal loss of substance and some erosion. From that point of view, we're dealing with a combined case of erosion plus abrasion. As we want to shift the anterior teeth slightly to the front, palatal preparation is not necessary, as the substance has already been abraded. Then the base is built up with dentine mass. Core was placed on the anterior teeth to transpose the incisal edge to buccal. Then componeer was applied to get to buccal. This crown was also veneered, and a small amount of color shade was added. In this case, we used Miris 2 Gold, which resulted in a warmer shade. And finally, the crown is veneered with componeer. So far, we've not taken care of the axial inclination outside the incisors or the length. Shortening or reduction will be done at the end to adapt the dental arch accordingly. In this image, the teeth are extended. They again correspond to the lip contours. The lip is not symmetric. You can see this downward convex arch and this upward concave arch. Nonetheless, it was possible to achieve somewhat improved harmony. The distance to the lower lip is now also more in congruence. Here again we have erosion on the buccal side. One can see the structures on the surface which imply erosion processes. At the same time, we can also observe lateral abrasion on this lateral incisor, add to which the tooth is inclined relatively steeply to palatal. This is why it was agreed to lengthen the teeth somewhat and to shift them buccally. Here we can see the preparation again. The irregularities were roughened slightly and reduced slightly on the surface. No preparation was performed outside the central incisors. Only sandblasting and etching were performed to align and fill this dental arch. Here too we can observe an abrasive situation. The abrasion on the incisal edges was largely caused by the central incisivus lateralis on the right and the incisor being shifted too far in palatal direction. The upper jaw is slightly too narrow there, so that the teeth are always interfering during lateral movement. If the patient now sleeps in a lateral position, the jaw will be moved slightly on the pillow, resulting in grinding of the teeth and lead to abraded incisal edges. Patients are usually aware of this when they look in the mirror, as there is some asymmetry present. On the other side, we see no abrasion and the dental arch is not as sunk as on the side with abrasions. We agreed on shaping the bow-shaped jaw somewhat rounder, while at the same time creating more space here. On the right, we can see the diagnosis, and on the left image depicts the preparation, or to be exact, the non-preparation. With sufficient space to incisal and buccal, we have no loss of hard tooth surface. The teeth are now conditioned and roughened. And one can see that we've created more space by rounding the dental arch. This alleviates the bad habit of grinding teeth. And in this case, the lip profile is also important. The lips should always be assessed when people speak. This smile tends to attach somewhat to the incisors. Sometimes this is due to the dental arch being somewhat narrower and the teeth in the middle are slightly bow-shaped. This makes lip contact more pronounced in the middle. When raising the lip, this slides centrally over the incisors and occasionally causes the lip to stick, which results in this line. The same can be seen in patients where the central incisors are shifted palatally and where the lateral incisors have shifted far to the front. This is why the lip attaches to the lateral incisors, resulting in two bulges when smiling instead of a nice line. As soon as the situation is rounded off, the situation is alleviated. In this case, we are treating both bruxism and a diasthema simultaneously. Here, it is particularly important to check the occlusal condition with care. Bruxism in the anterior tooth region and simultaneous diasthema often lead to rotation of the anterior teeth and orientation in direction of the diasthema. Fortunately, this is not the case here. Although they are abraded, the teeth more or less stand in a row. The only exception is the incisor. If you see patients with individual rotated anterior teeth, it is usually the mesial corner of the incisal edge which points in direction of the diasthema. If such a diasthema is filled, the teeth acquire pre-contact. In case of protrusion motion or bruxism, this leads to higher pressure in this region, which has a negative effect on the restoration. Here, the diagnosis. Preparation proved necessary. although we only see natural abrasion, and this led to a loss in hard tooth substance. But the patient not only wanted to have the lost substance replaced, but also wanted aesthetic correction of the teeth. Two factors play a role here. If the diastema is only located in the middle, then it is recommended to remove a small amount distally, especially in the case of such trapeze-shaped anterior teeth. Why? Otherwise, the teeth would become too wide and the proportions between anterior and lateral teeth would no longer be correct. This is why some substance was removed distally from the preparation to have space for mesial build-up and to retain the proportions. Here you can see the matrix in the sulcus and how the contact point is being filled to mesial. And at the same time, we have no occlusal interference in the incisal region. Another classical example. We have palatal erosion, which leads to loss of the incisal cutting edge. The palatal loss of hard tooth substance eventually becomes so great that more and more of the incisal edge chips away at the smallest load or protrusion motion. And then presents like this. This is especially unattractive when the patient smiles, giving an inverted line to the lip profile. The decision was taken to add some buccal space. There was relatively little palatal layering, as the anterior teeth in the mandible usually result in relative elongation. This means if hard tooth substance is lost, palatal and incisal, the mandible follows suit, curls slightly and attempts to find contact with the anterior teeth. To avoid this, there was only little layering to palatal. The mandible was also restored for the protection of all teeth and to correct the occlusal conditions.